we're very fortunate to have Rob with us today, and please join me in welcoming him.
All right, thank you. All right.
And before we start, if you don't mind, put your pagers and cell phones to vibrate. Last time it was a musical ceremony for us.
Mine is on, but we'll see if I set it down over there, so we'll see if I don't get a call. Thank you for having me. I'll try to make this interesting, but I know that most of the participants today are coming from a very different environment. I'm gonna take a very macroscopic view of the health system and what is really going on. What I do within UnitedHealth Group, and you may know UnitedHealth Group best for UnitedHealth Care, is one of the large payers in the U.S. What you may not know is that we also have a lot of businesses that are very focused on trying to help the health system work better. And those are largely housed in our Optum business unit, which is where I was previously. I've spent 10 years within UnitedHealth Group. I came out of the private equity world, and hadn't been in healthcare prior to that. Came into UnitedHealth Group really taking a market view of healthcare and trying to get at what is really systemic, what's really driving our costs, and pursuing solutions that drive higher quality care and lower costs. We spend several $100 billion directly on healthcare out of UnitedHealth Group. We help our customers manage several $100 billion more. So we're very vested in this process. I'm going to try to shake things up a little bit for you today. I'm going to try to present some data that you may not have thought about it. I like talking to people in the transplant industry because you're fairly advanced in terms of not just how you practice medicine, but how you've shaped your part of the industry. And so I want to spend some time taking a look at transplant specifically as well. I'm going to take you through some analogies so you can start to see what might happen if buying a car was like buying healthcare, and it's not going to be as obvious as you think. We may buy stock if we have time, but you're a bright group, so I'm going to keep this thing moving, and I'll take questions as we go, but I'm going to try to pace myself to have time at the end for us to take some questions. So I'm going to put my clock out here. All right. The overall objective here is what I would say is when you hear about the healthcare dialogue that's occurring, in the public domain, there's a lot of perception of what is driving our healthcare costs in the U.S. and they're pretty disconnected with the reality. And so I always talk about for an industry that's really premised on diagnosis and then treatment, we're in a situation here in the U.S. where we're running around treating our health system and we don't have an accurate diagnosis. And so I want to present some of the data that is misleading us. I've already said that I'm going to come back to transplants. We're going to come top down on this thing. We're going to go very macro on the health system, what's happening in the population health. It's going to take a different view than what you've been presented in the past. I'm pretty confident. And then we'll get into transplants. So I'm going to start with a starting point that we've all been looking at, and then I'm going to slowly kind of debunk some of these things for you. One is there's been this data out there of this idea of the average life expectancy as a good measure of the effectiveness of our health system. And when we look across all these other countries, one of the things that I've found really interesting in the U.S. health dialogue is for as broken as we think our system is in contrast to other health systems in the world, we spend very little time looking at what other health systems are doing or how they're performing. We just run around and say, oh, we're too fat as Americans, we have all these health problems, we're drinking too much soda, we should do all these things. Let's just really look at what's happening here. So this is the data. You've got the entire world. The squiggly line, the line chart is, and I'm forgetting who I'm talking to. You guys don't need squiggly line language, do you? I usually try to make it a little more common language depending on the group. But and by the way, this isn't my day job. This is kind of my hobby. I just, I found that as we discover information, we want to get this thing out there. My main job today is finding business models that we think are going to drive meaningful affordability. But you see the per capita expenditure, which is the right axis for the Y chart, and you've got the average expectancy of life, and you see where the U.S. is. I've circled it. So, everybody's saying, okay, our life expectancy is fairly far down the curve, and look at our cost curve. So we're out of whack. We're not getting all this life expectancy, and our costs are too high. So you've seen that data. What you may not have seen is, and this is just really more for your interest and for fodder at your next barbecue, if you adjust for one factor in the U.S., which is our violent death rate, we are the #1 longevity country in the world. All right, and we can give you all sorts of data about cancer survival rates. We're 20 percentage points ahead of many of our European counterparts. The outcomes in the U.S. system are fantastic. So when people run around saying we're getting ripped off, we don't have a high-quality system, and they use the type of data out there around life expectancy, it's a bad correlation. You can't blame the health system for the fact that we crash our cars and we murder each other at a much higher rate than Japan does, who is, I think they meditate more, and they're riding the train. So is that the health system's fault? No. All right. And the only person that has an excuse for falling asleep is Marwan, who is operating on a 7-hour time difference, just coming back from the Middle East. The other data that's out there is infant mortality. You guys have heard these two data points thrown around. We have the same issue here where we don't take into account our gestational profile in the U.S. is much different than what we find in other countries. And once you adjust for that, we go from being like 38th in the world to 3rd. All right, so we have people who are waiting longer to have babies. We have higher prevalence of fertility treatments. We also have sociological factors that has 40% of our babies in the U.S. being born into a Medicaid environment. The other thing, we actually count babies often with 22 weeks gestation, whereas other countries don't. So we've got all these factors going on. So our two biggest factors that run around that we judge the quality of the health system actually fall apart pretty fast. Have you guys seen that data before? Some of you? All right. Is it interesting?
Ready.
Good. All right. So I'm on your side. All right. We think we have a high-quality system in the U.S. What I want to explain to you is what's going on, why we're spending double in the U.S., because that's not as excusable. All right. The fact that we're down on the life expectancy, I can explain. Why are we at double? The cost. So the question in the room was does the violent death rate affect the treatment cost? I don't know. That's an interesting question. I suspect it's negligible. I do. We might have more car accidents or shooting victims coming in. I'll show you where the costs are. The costs are in orthopedics, cardiovascular, cancer, things that are less related to a bullet-inflicted type of issue. So I usually do this in a bit of a Socratic way, but we're a little jammed on time, and you're a savvy group. So we went out and we looked at other countries. This goes to my comparison of other countries. This is the U.S., our body mass index, the percent of people with a BMI in excess of 30 across different countries relative to our per capita expenditures. And you guys can go out on the World Health Organization. You can play with this data yourself. And we did a correlation between our per capita health expenditures and our body mass index, and it's about 0. All right, the R squared of our body mass index relative to the other countries driving the healthcare costs has almost a 0 correlation. Okay, and I want to make this really clear. we're not saying that body mass index doesn't drive healthcare costs. What we're saying is it doesn't uniquely drive the U.S. costs. We are not significantly obese relative to the rest of the world enough to justify it driving costs in our system. So we looked at percent of the population that smokes as another one. These are things we often hear about. You know, we got obesity, you got smoking, you got all these things going on. The R squared is less than 2%. So basically, we would say within that range, you can't rule out at 0. All right. So, and what kind of upsets us is the amount of energy that goes into these other areas. All right. And so we have a limited amount of resources. Let's focus them on the things that are really driving the spend. We looked at cholesterol, still fairly negligible. So what we started to do, this chart actually starts to point to some of the things that are going on. If you draw a line through the line chart on the per capita expenditures on health, you can start to see the rest of the world isn't that variable. All right? It starts to normalize around one line, and we are the outlier. Okay? So something is going on that's very systemic and very uniquely American that is not tied to our biology or our behavior. All right? I'm not saying our biology and behavior is great. I'm just saying it's not driving the upper part of that graph. It's driving the lower part. And for people that want to really cling to that, I say, you know, that's right. Health issues are driving a lot of our costs. It falls in that bottom part, and the good news for you, if you want to focus on that, is you have a global marketplace. All right? But if you run around in the U.S. and you think you're solving the uniquely U.S. issue by solving those problems, you're not going to.
Can I ask you a question?
Yep.
The real reasons why costs go up. If that's true, and the health industry, meaning insurers, are aware of that, then why do they focus on that? Is it just a way for premiums to be changed to generate money because we need money? Or why focus on those things? Hospitals are not hiring people who smoke, and et cetera, et cetera. So why would they focus on those issues if they have that information?
All right, so the question in the room, I'm just going to repeat it because I believe we're broadcasting, right, is then why is the health industry, why is the health insurance industry, if they know this, why are they so focused on improving health? Why won't people hire people that smoke? All these other things. I'd say two things. One is it does drive costs, all right? So I'm just saying it's not going to save the American health system. So you can affect costs. Let's say that of our GDP, 9% of our GDP is driven by our health, all right? Just like the rest of our 18 percentage points of GDP that we spend on healthcare. My only question is, can you drive that down? Could you make it 8? I don't know. But if you go after the systemic issues, I certainly think you can make it go from 18 to 13 a lot faster in approaching other people's health. The other thing I would say, before I get to this, not everybody's seen this presentation, right? I presented this to a Chamber of Commerce, and they asked a similar question. And I'm like, okay, there's 95 people in the room. We now have about 300 people in America that actually understand it. Because I'm going to get through what's really driving it, and you're going to piece together and connect the dots. I hope you will, if I've done my job. So I don't want to bog too much on it.
I think what you mentioned in those past few slides is that the smoking and the obesity are driving the excess cost differences between the United States and the rest of the world. Like it's known to contribute to excess costs, but those problems are also present in the rest of the world too, and the incident rates are not significantly different in the United States.
Correct. That's exactly my point. So, yes. So I'm going to keep going. I want to give you a sense of where we spend our dollars. The other thing I would say too is, when you look at the problem that's here, it's very hard to address, and so but it's highly addressable. But a lot of people want to focus on what they can control, and if you look at who's really buying health insurance today, it's the human resource departments. And their view is they really want to engage the people, and so they're going to go after the direct health contributions. So the big areas, if you look at where the expenditures are, you've got orthopedics, cancer, cardiac. Between the three of them, you've got about a third of the expenditures in the health system. You've got obstetrics, you got the injury, so that's where you'd pick up, some of the violent death. It impacts our life expectancy averages more than it impacts our health expenditures, is my guess. Digestive health, et cetera. So you can see. I highlighted cardiac because I want to give you an example. Okay, this is our this was our number 3 cost in the U.S. health system, and I want to show you a couple of things that start to point to. This is one marketplace. It happens to be New York City. This is the cost of a bypass graft, and the range you have in the same city. All right, it ranges from Hospital A doing about $22,000 for a bypass graft. This is clinically normalized. Hospital A doesn't have a bunch of people, healthy people that are getting bypass grafts. And Hospital Q doesn't have a bunch of sick people, and $71,000. And so you start to ask, if this was a car marketplace, if you could buy a, what would be in that price range? An Infinity for $22,000 on one side of town, and it was $72,000 on the other side of town, would that marketplace persist? Never, right? So it starts to give you an inkling of the level of competition that's happening within these marketplaces. It really doesn't exist on a price basis. The other thing is, if somebody did try to sell an Infinity for $71,000 when somebody else could sell it, who's going out of business? The person selling the Infinity for $22,000 or the person selling it for $71,000? Obviously, the person selling it for $71,000. What I'm going to prove to you is in healthcare it's the opposite. All right, the person selling the bypass for $22,000 is who I would not want to be an investor in. All right, they're going to be at a disadvantage. They don't have the infrastructure, they don't have the real estate, they don't have the marketing, they don't have everything else. So if you look at what's going on in cardiovascular disease, you look at us versus the rest of the world, we are treating with bypass graft and angioplasty at 4 times the rate of the UK. All right, and the UK is a bit of a suppressed market, but because of socialized medicine, but it's not 4x. All right, there's no clinical explanation that has been offered to date. Bypass grafts at double, stents are at 4.5 times. This is our number 3 cost in the health system, and we're at 4 times the prevalence. So people are running around saying, "Oh my gosh, we're too heavy. We have all these dietary issues," and they're running right past the fact our number 3 cost is running at 400% of what the rest of the world is. All right? If you look at the scanning and imaging that goes along with that, just happens we have 4 times as many machines. So you're starting to get a sense of, is this a demand issue, around people's health, or is this a supply issue where we just have so much supply? All right? And I can throw out more stats. You've got a good chunk of the U.S. health system. The hospitals are between 50 and 60% capacity. So you got a significant amount of supply. And I'm going to get ahead of myself a little bit. You're at 50, 60% of capacity. What is over that hospital? I'm going to keep you guys awake. What's over every hospital? Clouds, sky, birds, what else? A crane. A crane, right? We can't stop building. We're at 50% capacity. We just keep building. And I'm going to show you why. All right? And I'm going to start to go this way. So in a 30-minute conversation on a competitive strategy with a health system CEO, which words will be said most frequently? Efficiency of care, quality of care, footprint, or patient experience? Footprint, right? It's like, is it a word? Is it even a word? I mean, but you walk around the health system and it's just footprint, 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 footprint. Why? Right? Well, I'm going to show you why. So how do consumers choose their health care? The number 1 criteria for a consumer is the appearance of the facility. All right? And the number 2 is proximity to their home or work. And they have no other data, by the way. They have Google Maps, and that's it, and their windshield. And so they get in. If they're a smart consumer, they look for a crane. They go to the crane, and the likelihood on the other end of that is a hospital, and that's where they go, right? We were talking to a health system the other day, and they said no self-respecting health system doesn't have a crane over it. That's how you get in the club. So some stats around this. 203,000 physician offices in the U.S. Okay? 203,000. There's only 121,000 gas stations. All right, and I just want you to get your head around that. All right, and you say, well, what's the big deal? One, it shows you how people are competing. All right, we have a health system that's competing on infrastructure. A comparison for a lot of us might have been the airline industry in the 1970s, when you had price regulation, so they couldn't compete on price. And so what did they compete on? On time. It was the experience. It was all the amenities. All right? And who could afford to fly in the 70s? Nobody, right? I mean, none of us. I grew up in a station wagon. I don't know how you guys got around, but I don't know who still has like car sickness side effects from that. But like our kids' generation, they're on planes, right? We got rid of the price regulation, and now what do you compete on? Price. You go right in, the system compares on price, and that's how you choose. You know, before it was whatever, whoever had your amenity loyalty. That's kind of what you have in healthcare here, is proximity to the home. And then you start to hear about fragmentation of information. You hear about fragmentation of care, variation in care. If you look at the amount of fragmentation that you have just location-wise and in your facilities and in your practice patterns, this is part of it. All right, you have too many things out there. So if you look at healthcare since 2002 and 2008, and this follows the U.S. economic census, healthcare is the gray chart, and it outpaces every other industry. And what I think is really interesting is that is the same time period when we've all been running around saying we can't afford healthcare. All right, in 2008, we hit the Depression. So everybody who lost their job and was facing personal bankruptcy, the first thing that they do is go out and put an addition on their house. Did anybody? They couldn't even get the credit, right? But what are we doing? We can't stop. And what are we adding? Children's hospitals, specialty clinics. It's not an aging population issue. And I even put population over 50 on there so you can see where that's indexing out. We have HCA as a public company, right? You guys aren't public, but you may have public debt, where you have to report your prevalence, your capacity, and they're at 55% capacity, 45% vacancy. When we look around, I live in Minneapolis, a lot of them have public debt and they have to report. It's all 55 to 60% capacity. So you just have a massive amount of capacities. They all have built and continue to build. All right, so if you look at orthopedics, which was our number 2 driver, well, that was our number 1 driver, we're at 55% of knee replacements. And one of the things in my old role, we talked to 30,000 people a day who were trying to find high-quality care, and nobody was, one of the things I often hear is, yeah, it's the American consumer, they just can't wait, they want to, keep playing tennis till they're 75, it's unrealistic, we should tell them no. None of them are asking for knee replacements. I haven't talked to anybody yet who's like, I insist on having a knee replacement. This is being prescribed to them, all right? And many of them are probably clinically merited. The question is it at a rate that's this much ahead of the rest of the world? I'll leave that to answer. So this is 08 data again. 26% of the hospitals are under construction. 33% of the hospitals are being renovated. So you had 59% of the U.S. health system under some sort of construction. And if you want to have some fun, pull up the trade publications for the healthcare construction industry, and it will be something akin to euphoria. I mean, you'll just hear, they're like, this party's never going to stop, this is unbelievable, this is crazy, let's just keep building. And then you look at the world we're in, where people aren't getting raises, people aren't profitable as organizations, people are facing bankruptcy. It's a complete dichotomy. So we're going to quickly buy a car. All right, so we're going to buy a Ford Focus from Detroit. And I'm an idiot, so I did Infinity. Is that why you guys were laughing? All right, I'm sorry. All right. Know your audience. Ford Focus. Thankfully, I got that right. How far would the average consumer drive to save if one dealer is $16,000, the other is $15,000? How far would the average consumer drive? The answer is pretty far, right? They're going to cross state lines to save $1,000 bucks. If they know they can save $1,000 bucks, they're going to. So let's invert it. It's 20 bucks, and their employer pays the balance. Okay? Now you're smart people. You're going to say this is obvious. Of course, they're not going to drive any farther, and there's your problem. They're not going to drive farther. They're going to go zero. It's an IQ test, and that's the problem. They should have to pay a portion of their cost of their car. All right, that's the obvious answer. What's not obvious, because, yeah, maybe that would help engage them in their health care, but I'm not sure that it would, because here's the real effect. What the real cost here is the fact that they're no longer competing on price, so what are they going to compete on? If you're a dealer, what are you going to compete on? How are you going to compete in this marketplace? Location, right?
But those products are identical. A Ford Focus upstate is the same as a Ford Focus downstate. The perception is a cabbage at Sinai versus Joe Schmo Hospital is going to be different.
That
May not be true.
that's a valid point. So this thought experiment is convenient because it's the same product. Now, again, I'll go back to my survey. A lot of you can buy all the billboards you want. I just went on a driving vacation, and half the billboards were for hospital systems. Half. I started taking a picture, and my wife thought I was crazy. I'm like, I have to take a picture. This is insane. And every one was promoting closer costs or closer location. It wasn't quality of care or anything. So from the consumer's perspective, they're still thinking about your building, and they're still thinking about where you were relative to where they are. It's still all geographic competition. But work with me here, because nothing's going to be perfect to healthcare, but you're going to start to get the picture. So they're going to compete on geography. All right, they have to. So you're going to have a car dealership on every corner. Okay, so what happens after they're on every corner? Then what do they compete on? Service. But it's not just service. It's not like oil change service, right? It's like back rubs and like lobster dinners and, right? Like free Maserati rides and all these other things, right? What type of car are they going to sell? Are they going to sell a Ford Focus? Wait, one stop off in this logic. What does the Ford Focus now cost? You got to pay for all this real estate. You got to pay for the back rubs. You got to pay for the lobster. You got to pay for the Maseratis. And I'm sorry, if you can come up with a Detroit car that would pull in people like Maseratis, I'll change my example. But for now, it's a Maserati. Huh? They own them?
I said, what's a Maserati?
Oh. It's a really fancy car.
I know what. Can't afford.
They're going to be selling Maseratis, right? Because what's the difference? And the Ford Focus is going to cost somewhere in the range of $30,000. It's not a $15,000 car. What do the headlines say in America everywhere? Nobody can afford to drive, right? We're all riding the bus. It's the health system, right? We've spent so much on infrastructure and non-value added overhead that now we can no longer afford our cars, all right? Healthcare. Are you seeing the analog? If we keep building, we keep adding infrastructure. So we have a $2.5 trillion, I'll give you some math. We have a $2.5 trillion industry spending $100 billion on infrastructure every year, trying to compete. They're doing the right thing. This is how you compete. If you want to get your consumer, this is what you have to do. What percent trend is that? 100 billion on 2.5 trillion. I'm just keeping you guys awake. It's 4%, right? 4%. You say, oh, that's not bad. 4%. We're in a 7% escalation. The problem is this. It's not on care delivery. It's on consumer acquisition. All right? And so you haven't delivered any care. You haven't driven 4% increase in the cost of delivering care. You've delivered 4% increase in acquiring the consumer. All right? So if you're a health system, for everybody that you acquire, you've spent somewhere in the range of $2,000 to get them to walk through your door. So if you prescribe diet and exercise, I can assure you you've lost money. All right? If you give them a stent at $16,000 for 40% margins, you've made money. Okay? The health system's smart. What are you going to do? All right? And I've talked to all these CEOs. We talk to these guys. We're like, why are you doing this? Why do you just keep back surgeries, stenting, bypass graft on down the line? And they're like, because why would you have a good system like us go out of business? Right? I have to. I have to stay in business. It's a trap, and there's no way out of it. You know, people often ask me, well, who's the bad actor? Is it the insurance company? Is it these hospitals? There's no bad actor. This is the system. And people are going to play the game, and they're going to fight for survival. And as long as survival is rewarded by driving up costs, our costs are going to go up. Somebody comes out, they say, I'm going to save the American driver, and I'm going to offer a smart car. And they put in a little square thing to sell a little square car right next to the Maserati dealing place with back rubs and lobster. How long is the smart car guy in business? Yeah, like an afternoon, right? I mean, they're out of business. They have no chance. So you come forward, you say, I'm going to do the right ecological, economical thing for the American public, and you're rewarded by being driven out of business.
Unless you do high volumes, low margins, you have to like first innovation.
But no consumer will buy your car for $20. They're not going to drive in that thing.
You've actually presented a cost effectiveness sort of quality analysis, and they lost money on doing cardiac. And they showed that by improving quality, you can actually lose money if you keep your infrastructure the same and the payer the same. You have to change your paradigm in time.
Oh, in fact, when you came and fetched me outside, I was talking to an orthopedic system that has tried to deliver a higher quality or higher quality product for lower cost. And they're rewarded by, they're on the verge of bankruptcy. I mean, because it costs them more to deliver their care, and then they don't have these high-cost services to offset their cost structure. In orthopedics, you know, you can avoid a lot of surgeries that are happening, but it takes time, and it takes, you know, different pathways. It takes different disciplines working together, and it's not rewarding. There's another example that I can go through real quickly. Is there's an example where we have you guys invest in stocks, all right? And it would go something like this. I'd just basically pin each one of you, and I'd say, buy a stock. You're investing your retirement right now. You have no person to consult, and you just got to buy a stock right now. And what happens very reliably is people buy the top 50 brands in the world. They buy Google, they buy Apple, they buy Ford, they buy, I mean, give you the top 50 brands, they're on the top of your head. eBay, you know, whatever. Then you put up the top cash flowing businesses in the world. China National Petroleum, Apple does make the list. You got Alcoa, you have a bunch of others that nobody bought, right? And so then the question is, okay, what's the parallel? The thing about the financial system is that if we bought stocks that way, if we as consumers ran into the financial system and bought stocks along the top 50 brands, you'd change the basis of how people competed for investors. All right, it would no longer be about generating cash flow, which could be the parallel to healthcare outcomes. It would be about building a brand. You'd have to build a brand. You'd have to spend a ton of money to build a brand to attract investors to move your stock price to be able to have an efficient cost of capital to grow your business. Does that make sense? So by simply letting a consumer run around the financial system unguided, you destroy the financial system. It's exactly what's happened in the health system. They have no guidance, all right? And what you could say is there's this notion of this educated healthcare consumer. You know, they need to understand this. Well, people don't confuse in the financial system when nobody would ever recommend what you need is an educated consumer. We have to educate everybody on how to invest their money. Nobody does that. They say, no, let's get them a broker that actually knows what they're doing. So 55% of the trades in stock in the global system are placed by mutual fund owners, brokers, et cetera. They're by people that know what they're doing, and it helps keep the system running on the right metrics and cash flow. So one of the things that we've been really promoting for the health insurance industry and others is to engage consumers not just about their health, but how to find better care. You know, when we go and talk to the health systems, they're like, I'll stop building, I'll stop doing it if I can get consumers. You got to bring me consumers on the basis of high quality care and efficient care. And so that's what we're trying to do, is try to engage consumers and have them make decisions differently. Some of what you guys can do is think about the amenities that you want to line up to that consumer, because the consumer doesn't think about cost and quality. They think about time. We did an experiment where we offered consumers a quicker appointment than a comparable delivery system. So they got in same day or next day at the one system. At the other systems, it was just normal period of time that they would get in. Okay, no special treatment. 4% of the consumers that dialed inbound to this call line were planning on going to the quicker system already. 4%. What percent of consumers do you think chose, after being offered the quicker appointment, this other system? Half? Any other guesses? 90%? 74%. So when you think about, is it the same product to the consumer? Are they really differentiating between these two systems? You offered a quicker appointment, 74% of the people went there. So you start to think about, I would rather have a basis of competition on time and speed. And you think about the system today, it's actually set up the opposite, right? It's actually set up on, trying to maintain efficiency. Ironically, you guys aren't competing on costs, but you spend so much time trying to stay efficient because of the way the reimbursement patterns are. We get it. But there's so many things that fit together with this thing. So, when we're looking at how do you start to normalize this thing, we want to start to get the consumers making decisions on different choices. And there's a whole thing behind this. What I like about the U.S. transplant industry, and I'm going to get to some relevant data, I'm just going to dial through here, is that you've actually started to do this. So if you look at, I'm going to go to, well, let's look at liver. You actually do start to see quality differentials. Look at kidney. You start to see quality differentials in the marketplace. We spent a lot of time with your patients on how they make decisions. And we started talking to consumers in the transplant industry about, and I just want to give you a perspective, about 20% of the U.S. transplants go through our business. All right, so we're talking to a lot of consumers about where to get their transplants. We're obviously contracted with Henry Ford and others, and we focused on the highest quality centers. But when we engage with a consumer and we say, hey, this is a higher quality center, you're going to have a better outcome, what percent of consumers do you think made a decision based on that? Yeah, very low percentage. Statistically, I'd say it's 0. And we were having a very difficult time getting people to go to the higher performing centers. So we took a key off of the fact that we knew consumers were looking for time. And we started looking for correlations to time, and we started talking to consumers about what would correlate to time, what would also correlate to quality. You guys probably should know this because this is this does matter to consumers. It's length of stay. The higher performing centers often have a higher performing length of stay. And so one of the things you can talk to a consumer about is, why would you go to a center that's going to have you, so their overwhelming desire is to be close to home. And if we can say the closest to home you can be is home. So go and have the quicker length of stay and actually get home. Oh, and by the way, you have a better odds of actually getting home, which they don't entirely comprehend. But the number 2 statistic for a consumer making a decision around their transplant center is their costs, their out-of-pocket costs, which isn't entirely in your control, but you can think about those types of things. We spend as much time talking about how they're going to get reimbursed for their expenses as we do the center. One of the things we found is that when we started offering prepaid cards, when people went to higher performing centers, that the incidence of people choosing those centers went up dramatically. And that's just an administrative change. That's not a change in their benefit. That's not a change in anything. So we now have over 90% of consumers choosing a higher quality transplant center, or what we would consider, based on the measures that are available to us, a higher quality center. So you see the fight that we're going through to actually get consumers to behave in the way that we want them to behave. And in the absence of that, you guys just have to start opening satellite, consultation areas. I mean, that's what we saw. We saw this proliferation of real estate, and we're like, ooh, this isn't good. We've got to get you guys, the consumer, without having all this additional real estate. The good news from us, from a payer's perspective, just so you know, it's very well accepted in the payer communities that what you've done in transplant actually drives better outcomes. We see the length of stay differential between the centers as being significant. We see the costs as being significant. We see the outcomes as being significant. The key is that in transplantation, you've actually created a competitive market. We had, it's a couple of years ago now, we actually had one of the transplant centers decline a rate increase. We went in, our contract was up, and we went in and we said, well, we're going to make this easy. We're going to give you X amount of rate increase, and let's go on our way. And they actually came back and they said, we don't want a rate increase. The hospital actually said, I don't, that'd be like you going into your boss and saying, you know what, thank you very much, I don't want a pay raise, right? But that happened because they said, look, I know that I'm competing with XYZ center that is not that far away from me, and I don't know, I want to stay where I'm at. I think I'm more competitive on price. You just don't see that in healthcare, but that's the type of world that's going to start to evolve. You guys are just ahead. So if you look at complications, mortality, charges, one of the things is I operate in the orthopedic space, for example. You don't see this type of reporting that you have in transplant that goes and talks to an insurance company in the way that they think, in the way that they operate. So all this data collection that you guys do, albeit it may be a pain in the butt, you may look at it as an administrative cost, it actually makes the health system work much better. You just don't have it in the other parts of the industry. This is a graph of that whole battle that I described with the consumer. So this was the number of consumers choosing a centers of excellence. Why did I say it's 0%? Because that's about the contracted volume in the centers of excellence network. So there was 0 incremental. And then what we saw is without increasing the size of the network, the number of percent of people choosing a centers of excellence went up dramatically by using language that was meaningful. When you look at so we've invested a lot in our consumer engagement. And the big thing for us, when we look at it from your perspective, we are trying to get you guys to grow dramatically. We want volume going to the higher performance. We want the profitability flowing to those parts of the health system. I think the big challenge we're running into is just in a lot of these cases, you get into the bigger practice areas, you're going to have entire facilities going out of business. And so now you get into this challenge, and it's not for the faint of heart. So anyway, we are thinking about it from everybody's perspective. I think, if I were to summarize, we want the consumer to win, but if you think that the insurance industry doesn't want a profitable health system, we do. That's the most stable health system we can have. If you think that we wouldn't rather that the doctors were getting paid more than the construction companies, we would. We'd rather the money went to the doctors. And so, when we talk to a lot of the doctors, they're like, well, where's the money going? You hear this whole thing. The money went in your building. Maybe not here at Henry Ford, but in a lot of these places, it's where it went. All right? So there's a local system in Minneapolis that just filed their public information. They went from 6% margins to 2% margins in 1 year. And the only way you do that is through construction. That's the only way you can destroy your profitability that quickly. It's not pay raises. It's not. And so what do you have? You have a system that's now going to go clawing into the employee base to try to pay for it. Anyway, I'm going to take questions. So we're about 5 to 5. Is that as much disruption as you wanted?
Yeah. Thank you very much.
All right.
So we'll take some questions from the floor. I think there's many intriguing questions. Please.
I have a question on it because the presentation was very good, and I can understand, where the fraction of the cost that comes from. But even in comparing two equations, you still have to look at how efficient you are in providing that care. And so you build your business and you have your time, but still you have to move. And how much it really costs you to provide that care. So how are we going to work that into the equation?
Yeah, so the question was, you want to compete, you want to know what the costs are. So who's the most financially literate person here about your health system? So what percent of your costs are infrastructure versus labor, gauze?
Well, if you look at the capital.
Yeah, just your total income, your whole financial profitability. If you look at the cost to sustain the facility versus the cost to employ the physicians, nurses, custodial, etc., what percent is it?
Well, the only issue I have with, as we talk about here is our operating expenses, all our labor, what we put into it, and when we look at, we're not immune to put up with the cost of it. I don't represent that hospital, but there's cash flow, the operating cash flow, which isn't shown in the margin. When you mentioned your margins rate of about 6%, 2%, you really would do that instead of depreciation cost.
Yeah.
But that doesn't drive the cash flows that are, that you can reinvest or moving forward. Here, back to your question, we're running, our margin system, we want to get up to a 3% profit. We're running in that 0.5% overall. When we look at operating costs, really our labor is our number one cost overall. So number 40 is, you're looking at percent of total.
Yeah. Yeah. So what you're saying is you don't really amortize your cost of the building when you think about your income statement. You're saying, I've got my variable costs. I have all my buildings. And then my biggest expense, your biggest expense is your employees from there.
It really is. I mean, when I look at a facility like the Detroit campus,
Yep.
or all these different buildings here, they've been depreciated. Our higher margins are down to but at the same time, our newer facilities, lower margins so we've got the depreciation costs that are being expenses into these new facilities.
Right.
At the time, we have, we're not replenishing our capital at our depreciation rate either.
Right.
And that's a big concern. Being able to put the knowledge into to sustain current operations.
Right.
As opposed
Right. But can I point out something though? Because I do think this does get to some of the challenges in the health system is, because you have a not-for-profit environment that's so prevalent, the capital doesn't always look the same way as it would in the private sector, right? So you raise a bunch of money to build a building, right? And then you got a bunch of operating costs, and you look at the building as not being an expense in the way that a private sector would, right? A private sector would say, I put $100 million in that building, I need a minimum of $15 million of positive cash flow against that, which is going to imply any margin below 15% is complete failure, right? Because I got a $100 million asset sitting there. In a not-for-profit, you can say, I got a $100 million asset sitting there, but it was contributed, I don't have to depreciate it, and so it starts to mask some of those costs. And so, right? And so you can start to look at your labor as being a higher cost. But then you start to say, yeah, but I've got to replenish the capital because I have to continue to build, right? You were going to say something?
And I think what we're probably done there is missing the legal side of the hospital, so in the U.S. fixed costs, and if we have to fixed costs, depreciation of DNA and labor, fixed labor expense, so that's the U.S. physicians very much understand. Fixed healthcare, this is basically a fixed cost business, so 2/3 in your cost structure is actually a fixed cost. The only place you really start learning that and online is the labor. The other thing that I think we got to acknowledge is that it's unique to this business in general is investing in property that these big capital expenditures, unlike many industries where you would expect that to decrease in the this industry, it actually increases most likely the labor because you have to have it out from its controls to run it. MRI machines you got to pay to run it. ORs you got to be able to operate the things to use this. So in this business, making an investment in property type equipment actually drives up the volume of labor costs.
Right.
Definitely makes other industries.
I mean, so I want to come back to the question so that was good. Thank you for contributing a lot of that. And just for people on the phone, I mean, there was a discussion about what are real costs that affect your cash flow. What are the measures? And there's really two views that you can look at. One is that a lot of your costs are variable, and the other is that 70+% of your costs are fixed. And I think what I hear more often when I go around the system is that they're largely fixed. The 70% plus is fixed. I've got to have the staff show up. It's got to populate the building. It's got to populate the labs. It's got to populate everything else. So you're very sensitive to volumes. And when you look at, I think there was a bunch of articles about in New York, there was a question about why is there such price disparity for the same treatment. And they all pointed to difference in infrastructure. They said it's the infrastructure that is the difference between the two. So when you think about efficiencies, I just want to make sure that you're thinking about it the right way. It's not, how fast you get something, an order into the lab or into the pharmacy. It's how do you actually compete in the system? What assets do you have to try to attract your consumers? And then what is your clinical judgment for how often that you are actually pursuing certain procedures? So meaning, do you need to treat that back surgery? Or in your case, it might be a bone marrow transplant. That's where we see, when we look at our statistics between different transplant centers, for example, the number one differential that we see in the total cost of a population treated is generally the clinical judgment. It's what is the prevalence of treatment in that particular population. And that just dwarfs the difference between, a procedure at $170,000 versus $200,000. There's just no comparison if there's an extra $170,000 procedure, which, by the way, it's always those marginal treatments that are the $1 million treatments, right? It's that one extra choice to pursue a transplant that maybe a comparable center wouldn't have done. Does that make sense? So I just want to make sure that you're pulling on the right levers when you think about efficiencies.
area where costs could be reduced without sacrificing outcomes?
Yeah.
Yeah, I think from the clinical area, I think I would look at the two outliers. One is, does the person really need a transplant, or is it just a matter of time? And the other outlier side would be, is this a futile measure at this point, where the cost will be driven? So on one end, it's unnecessary perhaps to provide, and the other one is the futility measure, which is the million or multi-million dollar, when if you put in all the odds together. But these are tough decisions, obviously, but sometimes we don't ask those questions. Like when you have somebody being retransplanted for the third time on the ventilator in the ICU, but they're 45. Well, the odds of probably making it would be probably in the low teens or 20%. So these are questions that we don't ask often enough.
And it does change. It does change how you're viewed competitively. So that $1 million, if you're running in that particular type of transplant, $170,000 average, you throw $1 million, it's going to move the needle on your average cost, and it's going to make you look more expensive as a center. And you may have a mortality on top of that.
Yeah, Dr. Payne.
So that the occasional excess case too may be what's responsible for some differences at the micro level in the hospital. It sounds like it's actually the first piece of it. To ask the question as to why the United States has so much money in the rest of the world, it's really not really. At least if I understood correctly, you're not suggesting that a lot of this is about which is that patients want it, whether or not it's necessary. It's more of a overcapacity based on the economics. We just basically have too many hospitals with too much capacity, and part of what that would be responsible for is the supply of reduced demand concept, which fills those hospitals with unnecessary procedures. On top of the fact that you just said 70% of the fixed costs related to the building.
Right. That's exactly what I'm saying. I guess I'd take it one step further. The thing that amazes me and others is that prices haven't escalated faster. Because there is no cap on expenses right now. And so I think it's only because people are trying to be responsible that it hasn't gone up faster. Because theoretically, the financing would be available to expand the system faster. And the thing that worries me, and part of why I took a role in the venture capital part of UnitedHealth Group, is what's happening in venture capital and private equity right now is the money is going into healthcare at an increasing rate. I'm sure you've seen this. You hear about it, you read about it, and it could make it worse because now capital is more available.
A very specific example, and I'm a cardiac surgeon, now involved in the study of transcatheter valve, things throughout the state of Michigan. Certainly, every hospital is trying to figure out how to build a catheter, hybrid OR, hybrid catheter, so that we can put $35,000 heart valve.
Right. Well, in transplant was that way. Yeah, and you were facing that in transplant, and I think from our perspective, we really wanted to try to prevent entry in transplant. Just to use a comparable, where you've got 700 transplant centers in the U.S., we don't need 1,000, and because you're going to have a proliferation of treatment choices that are made because you have to put the volume through, and so you're going to have more outlier cases. The other thing I'd just say about transplant, in my view, if you look at the U.S. versus the U.K., the transplant industry in the U.S. is a net contributor to bringing our trend down. We're more efficient in the U.S. in transplant than we are in other parts of the world.
I think so. When you were mentioning the catheter valve replacement, and if you see this for example, like medical therapy for stable angina versus angioplasty instead, or I guess for orthopedic it could be like physical therapy and conservative care versus aggressive knee replacement for certain injuries. I'm in the kidney side, nephrology, and you could look at conservative care versus dialysis in the very elderly with comorbidities. That's a controversial area right now. So, and then, so if you look at, and then even sometimes the kidney transplant side, thought is often to, increase volumes, because that's what, in the hospital can generate, in volume and everything, but sometimes the list is actually, throughout the United States, is full of some not full of, a small, at least, a not insignificant proportion of the list does have patients that may not need to be transplanted, and so those might be contributing to excess costs too. And sometimes I think that, like that's where the standardization, if applied appropriately throughout the centers and at every hospital, it could be very useful to offer guidance to physicians and providers.
Yeah.
What level of benefit is this aggressive intervention going to be appropriate for?
Well, when Marwan saw this presentation, it was called the Payer's Perspective. I think part of what I was trying to bring to the table is just to have an exchange of kind of what the payer's looking at and how they look at what you guys do, so that because you often see the HMO office deals with the contracting part. Well, that's not where the real work is happening in either entity of how we're approaching our various work. And I think what part of what we were trying to say here is there's a lot of alignment to what you're trying to do. You're trying to deliver high quality care. You're trying to grow your business. And what we're trying to say is, and we want the same thing. We want it to be on the basis of high quality care, and efficient care. Whereas today, you don't have that opportunity. You're put into a situation where you have to compete on geography by most measures, unless people can really tie it back to other data. And so, how can we work with you to get you out of that situation? And we were talking about earlier, the problem is for the big players. There's an interesting thing happening in healthcare. If you look at the insurance industry, it's consolidating, right? So Aetna bought Coventry, all right? And you'd say, well, why do I need to know this? The problem for the health insurance industry is there's more and more, the payments are coming from fewer and fewer players. And that's good and bad. It's actually going to make it harder to create competitive types of programs where, like if I won't focus on Detroit, but let's say I go into 70% of the Minneapolis market is comprised of 3 major delivery systems. If I try to put volume into one at the expense of the other in any particular practice area on the basis of quality and efficient care, there's going to be a backlash. Like let's say it's cardiac care, and we try to grow that particular practice. We say let's work together. We're not going to get in the exam room. We're not denying care, but let's look at how good you're delivering care across these populations. That's great. You're doing great work. We're going to give you more. We're going to get thrown out at the other hospital in cancer, right? So it's this battle where the insurance companies are stuck, just the same as you're stuck in this system. Is they can't create competition because there's too much of a backside flank that they need to think about. And so you got this weird thing where parts of the industry are getting bigger, the delivery systems are getting bigger. You almost need smaller players to start to unwind some of these things, which is what I think will happen. You're going to start to see smaller players entering this market with new models that are going to be successful.
Wow.
I guess that leads to the question that we're trying to get to, which is patients aren't going to make a selection because you're making all the wrong things. You're going to have to clearly. Providers are going to make the right choices often because our incentives are wrong. Hospitals are positioned to take the weakness. You get things pretty regular, but it should be pretty regular. The back surgeries are going to take the so it really payers all the cards. You start as a grad out and your incline is getting bigger as worse. You're going to say, kind of, we're going to not. You're going to do the private just so you're ridiculous. You guys just don't have worse thing. We say we expect you to do this or you to do that. You have to be here or there. It's a credit for diagnostic really is good. So you consider it the people that you can the rest of it is really strikes me as the payers, they don't think they need to drive the efficiency of the system. Ultimately, we're not saying you people do this time.
Yeah. So I think you probably said it better than I could. and for people on the phone, if you're still on the phone, is just, so really the point that was made was that the payers are really going to have to intermediate on behalf of the consumer and say, we're going to help you get to the better centers, or you're going to end up paying more. And you didn't say that piece, but I'm throwing that piece in. When you think about the ACOs, so let's just play this out a little bit, and we're over time. You guys can go if you have other commitments. I'll stay. I don't even know when my plane is, but I'll be okay. If you've got a center getting paid 100 pennies, okay, here's the ACO proposition. The ACO proposition is, okay, I'm going to come to you. I'm going to give you a population that you're paying 100 pennies to deliver care to. Here's the thing. I'd really like you to deliver less cardiac care, more orthopedics, line up to your evidence-based medicine, and that's going to be 90 pennies. And that's supposed to be something that's rewarding, right? So you just like cut your own throat, right? It's like, okay, great. Where is this deal a positive? And so it's a bad deal. It's a bad deal. So this is what the ACO propositions are out. And you got a lot of service companies are going out and they're saying, yeah, and that's great. And you'll pay me 10 pennies to help set up that program for you. So now you're really losing money, right? And so you're starting from a half a percentage point. What I think is going to probably be more viable is to say, yes, but I'm going to actually align a benefit plan around your ACO. And so I'm going to bring you incremental market share that will get you back above your 100 pennies. So your efficient care is actually going to deliver. Whereas today you're hearing a lot about, well, I've got this shared savings program. Well, let's be clear. You've already created the savings. They're just giving you a portion of it back. So you still cut your own throat, right? It's like you generated your own economics. So we're not seeing a lot of participation, in these ACO types of programs. Or they do, and they just find ways to work through it, that's what I would do if I were you, and get it to be over 100 pennies anyway. So, but as soon as you line a benefit up to it, and you can post your own price in the marketplace that isn't affected by the other delivery systems, and consumers can choose you on your price, that's when I think share is going to start to move, and you'll actually see, people truly getting rewarded for the cost structures. So those programs are coming, but the payers are in a pickle, because if they help Henry Ford set up that type of program, then what about the other delivery systems, right? And so, let me play that out one step further. So what may happen is everybody may end up with an ACO-like benefit that's in the marketplace, which may just work. So think about that. If you got Ford here locally, who has employees all over the urban marketplace and all over the state, for that matter, for this local population, they'd probably need multiple delivery systems that they could choose from that would create, a full geographic access. And so that's where you see companies out there that are starting to make these exchanges that are inside employers that allow them to choose from multiple ACOs. So there's a lot of energy and a lot of capital going into trying to create those marketplaces. And you guys should be aware, because what I think is going to happen is it's going to happen very fast. It's going to happen over, 3 to 5 year time frame, where we're used to in healthcare things happen over 3 to 5 decades. It's just slow. I think these things are going to happen fast, and you're going to have to adapt your systems. You're going to have to adapt how you choose to compete fairly quickly. And so what all these assets, all these buildings that were assets, could become liabilities.
Jonathan, you had a question?
Is there any data within United that shows higher rates of utilization of elective procedures in this marketplaces that have lower capacity utilization? And is there any data within United that also shows the difference in rates of elective procedure utilization in those marketplaces that are more dominated by for-profit delivery systems as opposed to
So you just helped my presentation. So the question was, do we have data that shows in lower capacity marketplaces is the treatment incidence lower, which actually would be kind of a knockout piece of data. Higher where capacity is higher, lower where capacity is lower. and yes, we do have that data, and there's a lot of data around, and I'm sure you've seen it, when the system owns, like imaging, for example, that the use is higher. That's obvious, and that data's out there. But we'll have to pull it. I think back surgery would be a really good one to look at, where we'll see on Long Island in New York, 35% back surgery within onset of symptoms within 30 days, and on the in the Manhattan it'll be 15%. So what would be interesting is, look where people are choosing to live for their practices. So do you have more capacity on Long Island than you have in Manhattan? Right? So that would improve it.
Back surgery might be a special case because there's no data out there that shows the biggest risk factor for having back surgery is the number of back surgeries who live in close proximity to you.
Yeah.
But that's a slightly different issue than sort of overall rates of utilization of elective procedures in a marketplace that is notably underutilized in general. So I'm not, the spine literature kind of already shows that, but that's related to physician capacity.
I think I misunderstood your question. I thought that was your question. I thought you're...
The kernel of your argument had to do with facility capacity utilization.
Oh, not physician capacity, facility capacity. Oh, yeah. Well, okay, so I'll just give you one that's readily available. So in Kansas City, there is, I think it's 3 times the per capita emergency room capacity than what we would find in, say, Minneapolis. And we see the emergency room prevalence significantly higher in Kansas City than when we see in other markets. And that's all facility driven. That's not practice driven. And there's a building binge of emergency rooms. Right? And they've killed urgent care. You can't find urgent care in Kansas City. So
so growth should not be on the top list of a strategic plan for the CEO.
So growth?
Growth.
I'd say, look, it sounds unfriendly. It should be stealing share, right?
Distribution.
Yeah.
Any other
Without building.
Without building. Any other questions for Mr. Webb? Well, thank you so much. We really appreciate it.
All right, thanks.
Very sobering.
Yeah, thanks for having me.